It's basically we're going to discuss the burden and the epidemiology in the local data that we have in Saudi Arabia. Then the type 2 inflammation comorbidities that usually associated with type 2 inflammation, asthma. And I try my best to do many cases as I can, but it's best to have a focused case that we can really have.
Dr. Adib, would you please make the screen full screen, because we are seeing the presenter.
Okay,
screen.
sorry.
Yes, it should be only full screen.
Okay, full screen.
Thank you. Sorry for interruption.
No, it's okay. Thank you so much for letting me know. All right, so here is it's a full screen now, isn't it?
Yes, fine.
Yes, fine, Dr. Adib, perfect.
Yes. So, and finally, we're going to have a couple slides about the data that showed that dupilumab, it's a very efficacious and it's a good medication to give in such patients. So, unfortunately, asthma is one of those chronic diseases that it's not only affecting patient clinically, but also it's affecting the health system, the healthcare system, as well as the society. It's affecting patients at multiple levels, including exacerbation rates that need to be going to emergency, and it disrupting the life, absence from work, causing damage that it's sometimes irreversible, and the side effects from medication that usually giving to those patients. And because of those exacerbation and chronic disease that they have, they develop other comorbidities that related to medications sometimes that we give to those patients. Now, along with that, the healthcare system is very overwhelmed with these exacerbations and these side effects from that disease that is not being controlled. So we're talking about occupying beds, utilizing a lot of resources, and so on. And the society also affected. Just imagine that they have kids that have severe asthma or having asthma that require their parents to stay at home. So it's affecting even families and affecting the day or the work that families can sometimes, they have to stop to do just to take care of severe asthma patient or uncontrolled asthma. So unfortunately, to be honest with you, we don't have so much data, local data, and that's one of the things that saddened me. Most of the data goes back to 2000s, before even the era, we're talking about the 20th century, when Dr. Al-Umairi and his colleagues tried to collect data about asthma and the prevalence in Saudi Arabia. And it goes in that days as high as 25% of people or Saudi population, they might have asthma. But most of the study has been done, it was regional study. It was not kingdom-based studies. And very interestingly, those asthma, most of them, they were atopic asthma. We are talking about 2/3 of those asthmas were atopic or related to allergies. According to the WHO, asthma is ranked number 19 in terms of disabled diseases in Saudi Arabia, and among the 26, ranked 26 in terms of mortality. And it's very saddening to me that we are in the 21st century, and we have still people die from asthma, despite we having advances in every aspect of medicine. This is, I would say, the most reliable, the most up-to-date prevalence that we have. It was done by Minister of Health with help of a group of scientists. It was back in 2013 where we have the National Household Survey. Even though it's not very reliable, to be honest with you, to try to give good prevalence or insight about prevalence in Saudi Arabia, because it was questionnaire-based, and it was patient answer about a question. Have you ever diagnosed with asthma, or have you been told you have asthma? And we know, as a specialized in asthma or in any field in medicine, people in Saudi Arabia tend to not to call asthma as asthma. They're afraid to call they have rubble or they have asthma. They like to call it allergy in the chest, or they call it حساسية الصدر, because I think the chronicity takes them away from that, and that's maybe sometimes affecting the prevalence if we didn't do it in a scientific way instead of just questionnaire based. However, with that, Asthma, we are talking about 4% of Saudi population that might have asthma, or probably they have asthma. And when we talk about 4%, we're talking about Saudi Arabia is 30 million people, and 4% of Saudi population, we are talking about 1.2 million people who suffer from asthma. And if we take that to the figure that Dr. Riyad mentioned in the beginning, where about 20% or 24% they have severe asthma based on GINA guidelines. Severe uncontrolled asthma. And the interesting thing, I found that it's across the board between male and female.
Dr. Adil, I think
yes, I broke up. Yes, the internet, it had an issue, but now I think I'm okay. So it's very interesting when the 13th administrative region in Saudi Arabia, we see that Makkah region, along with Sharqiya region, it has a higher prevalence of asthma. For me, as an allergist, it makes sense because common in the coastal area. The very interesting to me, it was at Qasim. Probably it's a very, very pollinated city, I would say, with a lot of grasses and a lot of trees there. Maybe that contribute to this, or maybe there's indigenous or genetic factors in that. So the very fascinating to discover, despite having low prevalence of asthma compared to maybe other diseases, but most of asthmatic patients, they are uncontrolled. We are talking about 2/3 of the patients reported, or the people. So we're talking of people, and among of those, about 61% they presented to the emergency or went to the hospital. And the cause of those, most of the time they said is secondhand smoking, or maybe the obese, which increase the risk of asthma. He did 2 studies with 10 years period, and he noticed that in 1986, the prevalence of asthma was about 8%, but in 1995, that went up to 23%, which maybe, because I saw 2 studies, maybe different regions, maybe that's showing that we still have increased number of asthma. It's becoming more and more, we see it more and more in our patients, but again, as Dr. Riyad mentioned, some of them, maybe they label them with asthma. These the studies that majority of the study has been done in Saudi Arabia. As you can see, it's back in the 80s and the 90s and maybe early 2000s, and mainly was in children age group. So we are lacking too much data, except that the one I just showed in the beginning, that it has adult patient population, but most of them it's a pediatric based or pediatric age group. So to just give an idea about the epidemiology in Saudi Arabia, I think 4%, it's very consistent with international. Of our population, they do have asthma. But we really need good clinical trials, or need the trials or studies that really can estimate our prevalence to guide our management down the road, inshallah. But the very striking thing, and as I mentioned in one of the slides of that study, despite having maybe reasonable prevalence of patients we have in Saudi Arabia or of that disease, we to have so much hospitalization and so much ER visits. We are comparing, this is air KSA, It was led by MOH and Dr. Salih Al-Muhsin. And back in 2008, it's very consistent with the study that was published in 2015 for the House Care Survey, where it showed that about 5 times more than European countries, our patients go to the emergency to take care of their asthma because of exacerbations or because of their asthma is not well controlled. And about 3 times than European numbers. Is quite significant, probably despite the, should say the prevalence that it's similar to the international figures. This is a famous figure that just show you the international prevalence among countries, including US, about 7%, Europe is 4 to 10%, and China it's lower than the rest of the world. And it's breaking up. Sorry, I don't know what's wrong with my net. So I'm back now. It should be okay now. But again, with those, about up to 50% they have uncontrolled asthma. But in Saudi Arabia, it's much higher. Up to 75% they have uncontrolled asthma, which lead to higher morbidity and mortality among the other burden that goes to the health system. So the asthma burden on to this way, the more uncontrolled asthma, the more exacerbation. We know that those patients who is uncontrolled have about 3-fold compared to people with controlled asthma to have exacerbations. Patients, and we're gonna have one slide about each one of them to just highlight those numbers. And it's affecting the lung function as well. It's affecting the the quality of life and healthcare related life, as well as increased patient on oral systemic steroid dependency. And if you look to those burden, it's most of the time is associated with type 2 inflammation. So the exacerbation burden on the health system is not only affecting the patients alone, but also affecting the expenditures and the hospital or the healthcare economy and the cost that may come with these exacerbation is not only affecting only the hospitalization alone, but also it's affecting the ER visits, also affecting the medication on the oral corticosteroid course. So to give a quick estimates, people who have controlled asthma, and we are talking here about severe, moderate to severe asthma. Okay, these figures for severe to moderate to severe asthma. Probably the cost of patients who have been controlled asthma, it's half of the patients who had uncontrolled asthma. Along with that, they have higher tendency of missing work, and we didn't take into consideration the effect on the GDP or the economy of the country, by patients missing work and other things. This is only the healthcare cost. So just imagine how much this can affect the health economic or the country economic status. The exacerbations is not only affecting the exacerbation not only affecting the health cost spending, but also affecting the lung function. We can see here patients who has less frequent exacerbation, they're declining in FEV1 is still there, but it's not as fast. People who has frequent exacerbation, they have double rate of declining compared to people with less exacerbations. And this is similar in the other study that exacerbation, they have decreased about 6.4% declining every 3 years when they are having those multiple exacerbations. This is very clear, and you can see the trend. People who are with no exacerbations, their FEV1, it goes, as we call it, age-related decline of the FEV1. But people with the higher exacerbation that we get, the more declining that we notice. People with one exacerbation per year, they have higher rate than the no exacerbation. but at least lower grade than people with more or two exacerbations. And unfortunately, this is very crucial. Those decline, or these declining in ABP1, most of the time irreversible. And you can see it with post-bronchodilator. The reversibility is not returning to what it used to be. So that's why we have to act up very early on and to prevent this damage that to occur to those severe patients. This another study that showed in Denmark showed that actually the lower ABP1, the higher mortality rate that patient may experience. So if you have a patient who has ABP1 between 50 and 79%, you have probably triple the risk of having to die compared to someone who has ABP1 more than 80%. And this goes to 5 times higher if it's less than 50%. So we have to be very careful, and we have to act on those patients before they go to this route. Sorry, need to close this camera. But this here, as you can see, and this is on the right side, as you can see, also in a British study that showed that lower ABP1 can predict the exacerbation, and if the patient is going to have another exacerbation, by about 60% when you have lower ABP1 or ABP1 lower than 50%. So we give steroid, and that's probably because of our last choice, and some of us, because we are afraid patient maybe deteriorate, so we give oral systemic steroid. But and on the long term, we know that sorry, it's breaking up. We know that once you have patients goes on oral systemic steroid, those patients mainly they tend to have more exacerbation and more severe asthma, and the higher oral corticosteroid the higher risk of exacerbation. As you can see here on the right side, compared to people with zero oral corticosteroids, okay, the whole healthcare utilization or admitted to the hospital or visiting emergency, it's about 3 times if a patient on high oral corticosteroids, and this is about admission. And similarly, you can see it on ER visits as well. Again, oral corticosteroid, sometimes it's work like magic. It helps our patient, but we all know the side effects comes with that medication. Actually, it's one of the most medication I hate personally, because on the long term, it causes a lot of issues, and even on the short term, I have a lot of patients, they have a lot of psychiatric issues because of being on the steroids, and some of them just stops taking steroid because of the side effects, mainly psychiatric side effects. But name it, we have peptic ulcer diseases, we have obesity-related, osteoporosis, type 2 diabetes, hypertension, CKD. So it's probably caused a lot of more harm than it can do good on the long term. So by now, we're going to have a video, 4 minutes video about type 2 inflammation and the mechanistic of type 2 inflammation. Sharif?
Yeah, doctor. Can you stop share, please?
Yes, sure.
Understanding the signs of type 2 inflammation and asthma. Asthma is a heterogeneous disorder that affects an estimated 300 million patients or more worldwide. The disease remains uncontrolled in 30% of patients in Asia-Pacific countries and 45% of patients in Europe. 25 million patients have asthma in the United States, where the disease remains uncontrolled in 50% of patients. Approximately 71% of severe asthma patients not treated with an anti-IgE biologic were ineligible for available biologics. uncontrolled persistent asthma, characterized by chronic inflammation and airway hyperresponsiveness, may lead to airway remodeling and reduced lung function in the small and large airways. Type 2 inflammation is an important underlying component of asthma. Type 2 asthma encompasses eosinophilic and allergic phenotypes. Type 2 inflammation occurs in approximately 50 to 70% of adult asthma patients. Key mediators include type 2 cytokines, IL-4, IL-5, and IL-13, as well as the antibody IgE. During an immune response, both IL-4 and IL-13 play an important role in class switching of B cells to produce IgE from the resulting plasma cells. Mast cell proliferation is promoted by IL-13, while upregulation of IgE receptors on mast cells is induced by IgE, IL-4, and IL-13. IL-5 mediates the differentiation of eosinophils in bone marrow. IL-4 drives the differentiation of Th2 cells, mediating the production of downstream type 2 cytokines. An additional source of these cytokines is type 2 innate lymphoid cells, ILC2 cells, which produce IL-5 and IL-13. At the tissue level, eosinophils trafficked by IL-4 and IL-13 to sites of inflammation contribute to airway remodeling and potential loss of lung function. IL-13 also affects smooth muscle cells, contributing to bronchoconstriction that leads to AHR. IL-13 mediates goblet cell hyperplasia and increased mucus production. IL-4 and IL-13 activate via a common heterodimeric receptor complex expressed by several immune inflammatory and airway cells, which may explain their overlapping roles in type 2 inflammation and asthma. Type 2 asthma encompasses a range of phenotypes, including eosinophilic and allergic asthma, driven by type 2 inflammation. As you consider their unmet needs, look beyond eosinophil and IgE levels to better understand type 2 inflammation in your patients with asthma.
You can share your screen, Dr. Adib.
I'm having a technical issue here. Okay, thank you. So, as we saw, that type 2 inflammation, it's one of the common or the main common cause now, or the pathogenetic mechanism in asthma. And unfortunately, this type of people having this type of disease, they have higher tendency to develop exacerbations and furthering declining in their lung function. This is quite famous picture where basically it defines phenotype, endotypes, and I know this may be confusing to a lot of people. We hear the word phenotype, endotypes, but to for myself to summarize and to make it easy, anything has mechanistic finding. This is what we call it endotype. So we have patients where basically overlap between allergic and eosinophilic asthma, as Dr. Riyad mentioned, and we have another group, what we call it non-T2 patients, where basically is neutrophilic or post-granulocytic asthma, but it's not the majority. And those patients, most of the time, they're not responder to steroid. A very interesting thing about type 2 inflammation or T2 inflammation asthma or inflammation in general, most of the time, from my experience, most of the time they don't present alone as an asthma. If you dig in, you will find a history or at least concurrent of a disease that patient present with. The most common one that is associated with severe eosinophilic asthma, it's allergic rhinitis. And I should say between 70 to 80% of people, they present with allergic rhinitis. Some of them, their allergic rhinitis progressed to become chronic rhinosinusitis, and about 40% of them, they develop nasal polyposis that required multiple surgeries and vests or polypectomy. This mainly in pediatrics, but we see it more and more now in adults. Patients, they have atopic dermatitis on top of their asthma as well. This entity, it's underdiagnosed. We start seeing it more and more now. We collaborate with our GI colleague, which is eosinophilic esophagitis. I say here it says 6.5%, but I can guarantee you this is way higher than that because we underdiagnose these patients, and most of the time they present with GERD-like symptoms or sometimes with the food impaction in their esophagus. So always look for other comorbidities that comes with severe asthma or type 2's inflammation. And this study or the database of OBCARD database, which is a huge database in Denmark, it showed that patients with severe asthma who have exacerbations at least 2 times per year, they tend to have other comorbid diseases. We're talking about 60% or people with severe asthma with other comorbid disease, they have higher risk of having exacerbations more than once. So patients with allergic rhinitis, they have about 14% higher chance to develop exacerbation 2 or more per year. And the same thing, or the higher figures that we see in chronic rhinosinusitis with nasal polyposis, and the same thing with atopic dermatitis. And this comes to the concept that we all agree upon, which is a united airway. If this one here is not controlled, we know that the lung is not going to be controlled, and vice versa. If the lung is not controlled, the nose is not going to be controlled, because it's all called airway. So it starts from the top all the way to the lung. So we have to control